Hello, I'm Louise Owen. I'm a neonatologist at the Royal Women's Hospital in Melbourne, Australia, and today I am going to be talking through the results of a randomized controlled trial looking at nasal high flow as primary respiratory support for preterm infants. So this trial was called the HIPSTER Trial, and this trial looked at babies who were preterm, 28 to 36 plus 6 weeks of gestation, who were less than 24 hours old, where there was a clinical decision to commence or continue non-invasive respiratory support after birth, and who had had less than 4 hours of CPAP. The intervention in this group was nasal high flow, instituted at 6 to 8 litres per minute using either Optiflow or precision flow devices. The control in this group was binasal CPAP of any type, bubble, ventilator or variable flow at pressures of 6 to 8 centimetres of water. And our primary outcome was treatment failure within 72 hours after randomisation. We did this as a multi-centre non-inferiority trial. We needed a sample size of 750 babies to prove non-inferiority of less than 10%. This is because we had no expectation that high flow would be superior to CPAP, but we knew that people may be happy to continue to use high flow if it was just a little bit worse than CPAP because of the perceived other advantages of high flow, such as infant comfort. So in this trial, our primary outcome was treatment failure, and in an unblinded trial we needed to have fairly robust treatment failure criteria. So to reach treatment failure, you had to be on your maximum treatment, which in the high flow group was 8 litres per minute, in the CPAP group 8 centimetres of water, and you had to fulfil at least one of the following: a sustained requirement for more than 40% oxygen to reach your saturation targets, acidosis with a pH of less than 7.2 and a CO2 greater than 60, or recurrent apnea needing intervention, or anybody who urgently needed intubation within that time frame. If you reached treatment failure criteria, CPAP infants were intubated and ventilated. The high flow infants, if they reached treatment failure criteria, could cross over to have rescue CPAP, but if they continued to reach treatment failure criteria, they were then intubated and ventilated. So the trial recruited from mid-2013 to mid-2015, and recruitment was actually stopped after 583 recruits on the recommendation of our Data Monitoring and Safety Committee. And this was not because of any safety issues, this was because there was a highly significant difference in the primary outcome already, which would be extremely unlikely to change with ongoing recruitment. So by this stage we had randomised 289 babies to high flow and 294 to CPAP, and with our post-randomisation exclusions to do with consent and errors in randomisation, we finally had 278 high flow and 286 CPAP babies who were analysed. So our primary outcome showed that 25.5% of babies who were treated with high flow reached treatment failure criteria. Of course, the converse means that 75% or thereabouts did absolutely fine with high flow alone. But on the CPAP side, 13.3% reached treatment failure criteria. This was a risk difference of 12.3%, so beyond our set limit of 10%, and so we were not able to show non-inferiority of high flow. However, when we look at our main secondary outcome, which was intubation rate, the intubation rates were much nearer: 16% of the high flow group, 12% of the CPAP group, and this did reach non-inferiority criteria. If we look at other secondary outcomes, the high flow babies had 1 additional day on respiratory support compared with the CPAP babies. The high flow babies did not have any pneumothoraces on their treatment, although total overall pneumothorax rates were the same. Nasal trauma was significantly lower in the high flow group, and there were no differences in major neonatal morbidities such as death, BPD, sepsis, NEC, PDA, ROP or IVH. So in conclusion, high flow therapy resulted in a significantly higher rate of treatment failure than CPAP when used as primary respiratory support for preterm infants with respiratory distress. It is, however, important to note that the intubation rates between groups were no different. Thank you.